So now we're going to talk about cardiomyopathies and then some of the valvular heart disorders. So in cardiomyopathies, they can be either of primary or secondary nature. Primary cardiomyopathies are diseases or disorders that are confined to the pericardium itself. They can be either genetic in nature, they can be mixed, meaning they have some genetic and some sort of environmental component, or they can be fully acquired. So just things that happen kind of over time that causes disease of the pericardium. Um, and then secondary causes are things like autoimmune diseases or endocrine disorders that are secondary to some disorder that is causing systemic effects. Other secondary causes can be things like toxins. The big offenders there are either alcoholic cardiomyopathy or cardiomyopathy caused by chemotherapeutic agents. So we're going to start with a type of cardiomyopathy called hypertrophic cardiomyopathy, or HCM. HCM is an unexplained left ventricular hypertrophy where we see this disproportionately large thickening of the intraventricular septum that also leads to a lot of abnormal filling. So you can see that in the picture here. The top one is a normal heart, and this is a hypertrophic cardiomyopathy heart with a really widened, this is the intraventricular septum. It's the divider between the left ventricle and the right ventricle. It becomes really thickened and enlarged in people with HCM. The other thing that they might sometimes experience are these what we call intermittent outflow obstructions. You can kind of see that in the picture here too. So the outflow is from the left ventricle into the aorta, and you can see is that that intraventricular septum kind of grows. It as the heart muscle contracts, it kind of pushes it over that outflow of the aortic valve, causing a significant obstruction into that with that outflow. And that has large impacts on the left ventricular function and causes increased pressure, increased hypertrophy. This is a genetic disorder, so people are kind of born with this particular problem. This is something that we know has a high increase in risk of sudden cardiac death in young athletes. So these are people who suddenly develop abnormal heart rhythms during exercise, and sometimes that can be fatal. We usually treat that with internal cardiac defibrillator implantation. We'll talk about those when we get to the electricity of the heart. Other things we sometimes do for patients with HCM, we might use different medications to block catecholamines. So these patients, because their cardiac output is reduced, they'll have increased sympathetic nervous system activation, so increased heart rate, increased contractility, but we don't really want that to happen because it leads to more kind of thickening and hypertrophy of the left ventricle and more remodeling, which is not a good situation for these patients. We can also do things like septal myectomy or ablation to try to reduce the overall size of the septum, especially if we want to try to prevent that outflow obstruction. And another thing we can sometimes do is something called biventricular pacing, where we insert pacing wires in both ventricles to try to kind of resynchronize the heartbeats. When heart muscles grow significantly like this, it has it causes a lot of disruption to the normal electrical activity through a heart. And the more the electricity is disrupted by growth, the less efficient the heart becomes when it beats. And so to restore some of that efficiency, we insert these pacemakers to kind of take over for the normal electrical activity to try to restore some of that kind of overall efficiency. So a person with HCM, some of the clinical manifestations are things like dyspnea. They often have chest pain, especially during exertion. They become intolerant of exercise, and they might have syncopal or fainting episodes. They are very prone to arrhythmias or dysrhythmias, again, because of all of that kind of restructuring and remodeling and growth of the heart. It has a significant impact on the electrical system, and arrhythmias become more common. These patients can also experience myocardial ischemia, even though they don't have coronary artery disease. So if you looked at their coronary arteries, you wouldn't see signs of plaquing and obstruction, This ischemia is being caused by this just massive increase in size of the left ventricle and all of this increased pressure inside of the left ventricle. And so those two things significantly increase the oxygen demand piece of that supply and demand. And that's why we see myocardial ischemia in these cases. It can progress to really end-stage heart failure with severe systolic dysfunction, and it's usually diagnosed by echocardiography. And what we see is that, again, that kind of increased septal size, but a non-dilated left ventricle. So we'll talk about what it looks like when it's dilated momentarily, but that's not what we see in HCM patients. So this is an example of dilated cardiomyopathy. You can kind of see on the picture here how the walls of the ventricles are kind of thin, but the chamber size is really, really large. And so the heart itself has grown really big, like there's a lot of hypertrophy, but it's not necessarily maybe in the walls themselves. There's just these really, really dilated chambers. These are just huge. So dilated cardiomyopathy, or DCM, is a really common cause of heart failure. And it's also the leading indication for heart transplant. And a lot of things can cause dilated cardiomyopathy. So causes can be genetic, they can be infections, they can be different toxins or drugs, alcoholism, chemotherapy, um, and oftentimes these are just idiopathic in nature, meaning we don't really even know what the cause was. Someone just develops these with no known reason. So again, you get this significant ventricular enlargement with a reduced wall thickness. And so the walls become thinner, but the ventricles are really enlarged or dilated. And they start to develop significant systolic dysfunction. So the heart muscle itself, the cardiac output, becomes severely reduced, and the ability to perfuse the rest of the body is impacted. So usually we identify DCM when a patient becomes symptomatic, and so things like shortness of breath or orthopnea, a significantly reduced exercise capacity. We bring them in and look at their heart structurally, usually with an echocardiogram, and we notice what we call a reduced EF, or ejection fraction. And an ejection fraction is the percentage of blood that the heart ejects with each contraction. A normal ejection fraction is about 50 to 60%. And so when we think about a reduced ejection fraction, it's 25% or less is what we consider reduced. With this dilation and reduced cardiac output or ejection fraction, we get stasis of blood. The blood is kind of just sitting within the ventricle, and anytime there's blood stasis, someone is at increased risk of thrombus formation. So sometimes for these patients, we'll bring them in and look at their heart with an echocardiogram, and we'll see a big thrombus just sitting in the left ventricle, which is a pretty scary situation to have for these patients. Dilated cardiomyopathy also predisposes patients to a whole host of abnormal cardiac rhythms. Many of them can be fatal in nature. Increased risk of things like sudden cardiac death happens in these patients, again, because this dilation and growth and hypertrophy of the heart muscle significantly kind of changes the structure of the electrical system, which predisposes to abnormal heart rhythms. Treatment, we often start with trying to reduce symptoms that are caused by this increased workload of the heart. So if we can reduce things like preload or afterload, anything we can do to reduce heart workload might be helpful. We often give anticoagulant therapy to try to prevent that thrombus formation from blood stasis. We can also use biventricular pacemaking like we talked about with HCM patients. But if patients with this condition become really refractory to any sort of medical or surgical treatment, they can become candidates for cardiac transplantation. If we have a dilated cardiomyopathy that is being caused by some kind of secondary agent, like alcohol or chemotherapy, we can, take away that toxin to see if it can reduce overall function. And we also, with these patients, encourage activity because that can sometimes help with reduction in symptoms overall. Myocarditis is another cause of cardiomyopathy, and in this case, it's what we call inflammatory cardiomyopathy. And so the manifestations that we see in these patients can range from really like non-specific things, like maybe some fever, myalgias, or maybe some mild exertional dyspnea, all the way up to hemodynamic collapse and sudden death. It really just depends on the level of inflammation and how kind of quickly this is happening. The most common cause of myocarditis is a viral infection. Some common infections are things like enterovirus or adenovirus, but really any virus has the potential, in many cases, to lead to myocarditis. COVID was one example, though some patients with COVID infections did end up with myocarditis. Um, Other causes might be things like autoimmune diseases like lupus, and sometimes bacterial or fungal infections or some drug reactions can cause myocarditis as well. We also frequently see this in HIV infection. Um, this development of myocarditis. So, very briefly, it's just when we get this activation of the immune response in the body from something like, again, like a viral infection or an autoimmune disorder, we can get leukocyte and other immune cells that start to kind of penetrate the myocardium, and that can lead to edema. And then, if that edema continues, some necrosis and fibrosis of the heart tissue itself, which can cause this cardiomyopathy. Um, Sometimes these things are just really self-limiting, so it's just supportive treatment until the myocarditis clears. But in severe cases, it can progress to significant dilated cardiomyopathy or DCM and cause left ventricular failure and life-threatening arrhythmias. Now we're going to move on to the valvular disorders, and we're going to focus really on the aortic and mitral valves and some of the hemodynamic changes that we see with these valvular disorders. So the valves themselves have some very specific functions. They really work to promote directional flow of blood through the chambers of the heart. The blood needs to flow from the venous side into the right atrium, into the right ventricle, forward into the pulmonary circulation, into the pulmonary veins that empty into the left atrium, and then into the left ventricle to be ejected to the body. We need that good kind of constant forward flow to maintain all of the normal hemodynamics and pressures within the heart itself. And so the valves help to maintain that forward flow, prevent any backflow, kind of keep everything moving in the direction it's supposed to be moving. Things that can cause dysfunction of the valves, some of them are congenital defects. Some people are just born with valves with maybe not the correct structure or makeup. Um, Sometimes this can be caused by trauma or ischemic changes. Many people develop maybe valvular disorder post-MI when they lose blood supply to some of the areas of the valves. Degenerative changes are very common over time through wear and tear and calcification and just aging. Valves can kind of fibrose and develop disorders. And also inflammatory kind of disorders. Things like rheumatic heart disease is a valvular disorder that happens after infection with rheumatic fever. So, when disruptions occur with valvular heart disease, sometimes we term them stenosis, which is narrowing of the valve so that it doesn't really open properly. So, you can kind of see that here. This is aortic stenosis. This is a normal aortic valve. And as it stenoses or hardens, that opening starts to get smaller and smaller. So there's distortion of the valve, and so it does not open properly. Sometimes that distortion of the valve causes it to not close properly, and then we get an incompetent or regurgitant valve. And now, instead of just this constant forward flow of blood, this incompetent or unclosed valve starts to permit backward flow of the valve, even when it's closed. Um, so we have regurgitation or movement of blood backwards in the system rather than kind of constantly forward. So again, we're going to talk about mitral valve disorders. We're going to focus on stenosis and regurgitation, and we'll talk about aortic valve stenosis and regurgitation. So this valve shows kind of some of the hemodynamic changes and functions that we see. A lot of the stuff we're going to talk about with these disorders is really related to kind of the pressure and hemodynamic changes they cause throughout the system. So in this picture, the thin arrows indicate direction of normal flow, and the thick arrows indicate the direction of abnormal flow. So in mitral valve stenosis, We get an incomplete opening of the mitral valve during diastole, and this causes left atrial distension and impaired LV filling. And so, again, that is mitral valve stenosis. So you can see that kind of right here. As that mitral valve becomes stenosed, it doesn't open appropriately, and that causes the left atrium, which is this up here, to kind of become distended and enlarged, and that impairs kind of the overall left ventricular filling. Okay. Let's see, what else do we have? So aortic valve stenosis is right here. And so the forward flow of the blood should move out of the left ventricle, kind of up into the aorta. And in this case, it can't. So we get an increase in blood in the left ventricle, which can also kind of back up into the left atrium. Here in mitral regurgitation, we get this backward flow across the mitral valve back into the left atrium. And here we have aortic regurgitation, which causes backward flow into the left ventricle, which should be moving up through the aorta. Okay, so these are some of the hemodynamic things that we see with different valvular disorders. And we'll talk about each of these kind of individually a little bit more. So starting with mitral valve stenosis. So in mitral valve stenosis, again, there's an incomplete opening of the mitral valve. And this is usually caused when the valve fibroses or stiffens, and so it can't open. So you can kind of see that in the picture. This is a stenosed mitral valve. Instead of opening all the way, it's just kind of this little tiny bit of opening. And so that it doesn't really permit good forward flow of blood because of that stenotic nature of the valve. So we get resistance of blood flow. And because the mitral valve separates the left atrium from the left ventricle, the normal forward flow of blood there would be from the left atrium to the left ventricle. But now that we're stenosed, the blood doesn't move very freely, and so blood remains in the left atrium. And so this causes the left atrium to dilate or grow or expand, and it also increases the overall pressure within the left atrium. That increase in left atrial pressure increases the pressure within the pulmonary venous system as well. The pulmonary veins, and that's kind of these red sort of veins sitting back here on the left atrium, they are bringing blood back to the heart from the lungs. And as left atrial pressure rises, it pushes pressure also back into the pulmonary veins. And this can lead back into the lungs and cause significant pulmonary congestion. And so because pulmonary congestion is the end result of all these changes, the clinical manifestations we see in our patients are signs and symptoms of this congestion. So things like nocturnal paroxysmal dyspnea, where people are getting kind of this intermittent shortness of breath, especially at night, or when they're lying flat. And so we call that orthopnea, when someone is unable to lie flat. Other things we commonly see because of these changes to the heart are things like palpitations. So as the left atrium dilates, it leads to things like premature atrial beats, atrial tachycardias, and atrial fibrillation. These are usually caused by the remodeling of the left atrium itself, leading to changes in the electrical kind of conduction that happens there. So again, that distension of the left atrium. Patients can also experience things like weakness and fatigue. This will also start to not only impact pulmonary congestion, but it also impacts forward flow and potentially stroke volume as well. Diagnosis, we usually can appreciate maybe a murmur when we're listening to heart sounds. And if someone's symptomatic or presents with a murmur, we would definitively diagnose this on echocardiogram. Treatment is focused on things that can help to reduce maybe cardiac output and overall relieve that pulmonary congestion. So we want to try to increase that forward flow of blood to reduce the pressure on the lungs themselves. So next we'll talk about mitral valve regurgitation, and this is when there's incomplete closure of the mitral valve with some of the stroke volume moving back into the left atrium during diastole. So again, when systole occurs, that blood should be ejected forward through the aortic valve, but in this case, because the mitral valve doesn't completely open, some of that stroke volume actually moves backwards into the left atrium. What causes mitral valve disorder is usually maybe structural damage to the mitral valve itself. It can be either chronic or very abrupt. Sometimes when it's abrupt, it happens in conjunction with maybe a significant myocardial infarction. People with chronic mitral valve disorder might be asymptomatic for years, even up to, a decade with this before they start to develop any symptoms. But over time, as the aortic stroke volume decreases and left atrial pressures increase from that kind of regurgitation of blood flow, we start to see an increase in pulmonary congestion. They also may develop enlargement of their left ventricle. Um, and we often can appreciate a murmur in these cases too. Atrial fibrillation is often common because of increased left atrial pressures. These are usually diagnosed on echo, and the treatment is to really try to reduce maybe preload. And if medical treatment is fails or if they become too symptomatic, we can surgically repair or replace that valve. So now we're going to move on to aortic valve disorders, and we're going to start with aortic stenosis. Aortic stenosis can be congenital, meaning born with it, or it can be acquired, and it's often acquired where we get this kind of wear and tear calcification over time. If you think about the aortic valve, it separates the left ventricle from the rest of the circulation, and so this is a valve that is really under kind of a lot of like pressure all the time, and so wear and tear on the aortic valve is relatively common, especially for patients with maybe systemic hypertension or other disorders that might kind of increase the amount of pressure that it's under. So this calcification really happens slowly. So oftentimes with aortic valve disease, people have a lot of kind of time that allows the LV time to adapt. But overall, it's causing this significant resistance to ejection of blood from the left ventricle. So as that valve kind of gets smaller and smaller, as that like opening to the valve gets smaller and smaller over time, as calcification increases, the outflow gets further and further obstructed. And if that obstruction becomes severe enough, it can lead to severe systolic and diastolic dysfunction and eventually heart failure, as that heart is working so hard to kind of pump through that stenotic valve. Diagnosis is really by appreciating a murmur and then echocardiogram. We often see with aortic stenosis patients too, like angina and dyspnea, because there is this real like overall workload of the heart. So this is angina that's not necessarily associated with coronary artery disease. Again, it's just because his heart is working so much harder to eject that blood through that stenotic valve. There's really not any good medical therapy for severe disease. Usually with aortic stenosis, if we know it's there, we're kind of watching it year over year to see how kind of stenosed or small that valve area is becoming. If it becomes severe enough that it starts to lead to significant symptoms or clinical manifestations or heart failure in a patient, then we can either replace or repair the valve. There are newer treatments now to kind of do almost like angioplasty to the valves to try to open up that stenotic area. So that often becomes necessary when this really progresses to more kind of significant levels of stenosis. And finally, we'll just talk briefly about aortic regurgitation. And so this is an incompetent aortic valve that allows blood to flow back into the left ventricle during diastole. And now we've got excess blood remaining in the left ventricle instead of being ejected forward. So this increases left ventricular filling and stroke volume. This can be either acute or chronic. Chronic aortic regurg is pretty well tolerated. People often remain symptomatic for a long time. But in acute cases, we see kind of more significant, like sudden onset of things like pulmonary edema, because there's this really large increase in left ventricular end diastolic pressure. So instead of there being really low pressure in the left ventricle during diastole that allows it to fill really well, that pressure remains high. And without good filling, blood starts to back up into the left atrium and then significantly into the pulmonary circulation, and that's why we get pulmonary edema in acute cases. Usually we don't see clinical manifestations in chronic patients until there's significant left ventricular failure, and then there's signs that look like pulmonary congestion and maybe some signs of decreased coronary perfusion.